Welcome to the Deep Dive. Today we're jumping into a really important topic, something that affects a lot of pets, especially as they get older, chronic kidney disease or CKD.
It really does. And we're planning to unpack it quite a bit today. We'll look at what CKD actually is, how it happens physiologically, how we diagnose it, how we use the IRS system to figure out how severe it is, and importantly, what treatment looks like.
And we're grounding this in some pretty solid veterinary resources, right? The goal is to make this complex stuff, well, understandable.
Exactly. Clear and actionable information.
All right, so chronic kidney disease. The name kind of suggests a gradual process. Kidneys losing function over time. What's actually happening under the hood?
Well, at its heart, CKD is exactly that, a progressive long-term decline in the kidney's ability to do their jobs. And they have so many vital jobs.
Like filtering waste. That seems like the main one people think of.
Absolutely. Filtering waste products like urea, nitrogen, and creatinine from the blood is crucial. They're the body's main filtration plant, really.
Urea, nitrogen, creatinine, BUN, and create.
Yeah.
Those numbers we see on blood tests.
Those are the ones. And when those numbers start creeping up in the blood, it's a sign the kidneys aren't filtering as efficiently. We call that lab finding azotemia.
Okay, azotemia. But I've also heard the term uremia. Are they the same thing?
Good question. No, they're related but distinct. Azotemia is the measurable increase of those nitrogenous wastes in the blood. Uremia is the clinical syndrome that happens when those waste levels get high enough to cause systemic illness.
So uremia is when the pet actually feels sick from it, like the vomiting, the weight loss.
Exactly. Increased thirst, increased urination, lethargy, poor appetite. Those are signs of uremia resulting from the azotemia and the kidneys failing at their other jobs too, like regulating electrolytes and a water balance.
Got it. Azotemia is the lab number, uremia is the sick pet. Now, kidney failure.
Yeah.
Can it happen suddenly, or is it always this slow CKD process?
It can be both. You can have acute kidney injury, AKI, which is a rapid loss of function, maybe from a toxin or severe infection. Sometimes severe AKI can, unfortunately, lead to CKD down the line.
Oh, okay.
But CKD itself is typically that slower, more gradual decline we're focusing on today.
Right. Let's go back to azotemia, the high-waste products. You said it's about filtering. Which part of the kidney is doing that filtering?
That's primarily the job of the glomeruli. Think of them as these tiny, intricate filters within the nephrons, the functional units of the kidney. They're responsible for that initial filtration of blood to remove waste products like urea and creatinine.
So azotemia specifically points to a problem with the glomeruli not filtering well enough. A decreased glomerular filtration rate, or GFR.
Precisely. It tells us the GFR is reduced. The other main part of the nephron, the tubules, they have different, also vital roles.
Okay, what do the tubules do then? Is not the main filtering.
The tubules are more involved in fine-tuning. They reabsorb essential things the body wants to keep water, electrolytes, nutrients back into the bloodstream after the initial filtration. They also secrete some other waste products into the urine and help manage acid-base balance.
Important distinction. Glomeruli filter the waste. Tubules manage reabsorption and concentration. Makes sense. Now, the sources mention 3 types of azotemia. Pre-renal, renal, and post-renal. Can you break those down?
Sure. It helps to think about where the problem originates relative to the kidneys. Pre-renal means the issue is before the kidney, usually involving blood flow to the kidneys.
Like not enough blood getting there.
Exactly. Think severe dehydration, shock, or maybe advanced heart disease where the heart isn't pumping effectively. The kidneys themselves might be healthy initially, but if they don't get enough blood flow, they can't filter properly.
And can that lack of blood flow actually damage the kidneys eventually?
Yes, absolutely. Prolonged poor perfusion can lead to ischemic injury, causing secondary renal damage. An interesting early clue for pre-renal issues can sometimes be that urea and nitrogen goes up more than creatinine, and if the tubules are still working okay, the urine might be really concentrated as the body tries desperately to hold on to water.
Okay, so that's pre-renal. What about renal azotemia?
Renal azotemia means the problem is within the kidneys themselves. There's intrinsic kidney damage, fewer functioning nephrons to do the filtering work. This is what we typically think of with primary CKD.
So the filters themselves are damaged.
Right. And often with renal azotemia, especially CKD, we see urine that's not well concentrated. It might be isothenuric, meaning it has the same concentration as plasma, around 1.00 to 1.012 specific gravity.
Why is that? if the filtering part, the glomeruli, are the main issue with azotemia.
Yeah. Because the concentrating ability, which is largely a tubular function, often gets damaged earlier or more severely in the CKD process than the filtering capacity. So you might see dilute urine even before the creatinine gets super high. Renal azotemia can be from primary kidney diseases or, like we said, secondary to long-standing pre-renal or post-renal problems.
Okay. And the last one, post-renal. Sounds like it's after the kidneys.
You got it. Post-renal azotemia happens when urine can't get out of the body normally. Think urinary tract obstruction like a bladder stone lodged in the urethra, or a tumor blocking your ureter, or even a rupture in the urinary tract like a burst bladder.
So the kidneys might be making urine okay, but it's backing up and leaking out.
Exactly. The waste products build up because they can't be excreted. Urine-specific gravity can be variable in these cases. And just like pre-renal issues, if a blockage isn't relieved quickly, the back pressure can cause significant secondary damage to the kidneys.
So just seeing high BUN and creatinine isn't enough. You really need more clues to figure out why they're high.
Absolutely. You need to look at the whole picture. A urinalysis is critical. Checking the urine concentration tells us about tubular function. We need to consider the patient's history, clinical signs, hydration status, and sometimes imaging like x-rays or ultrasound is needed to rule out things like obstructions.
Makes sense. Okay, let's shift to the causes. What actually leads to that renal azotemia, the damage within the kidneys themselves in CKD?
Well, there are several primary kidney diseases. One important one is glomerulonephritis, inflammation of those glomeruli filters. Often it's immune-mediated, where immune complexes get stuck in the filters and cause damage.
Okay.
Another is amyloidosis. This involves the deposition of an abnormal protein, amyloid, usually derived from something called serum amyloid A, which increases with chronic inflammation elsewhere in the body. This amyloid clogs up the glomeruli.
And what's the consequence of damaging the glomeruli like that?
A key consequence, especially with glomerulonephritis and amyloidosis, is protein loss into the urine. We call this protein-losing nephropathy, or PLN. Those damaged filters start leaking protein, like albumin, which should normally stay in the blood. Over time, this damage progresses and leads to reduced GFR and eventually renal azotemia.
So diseases directly hitting the filters.
Yeah.
But you also mentioned kidney damage can happen because of those pre-renal or post-renal issues.
Yes, that's a crucial link. If the kidneys are starved of oxygen due to prolonged poor blood flow, that's ischemic injury from a pre-renal cause that can permanently damage nephrons.
Right.
Similarly, if urine backs up due to an obstruction, a post-renal cause, the increased pressure within the kidney can physically damage the delicate structures. So CKD isn't always from a primary kidney disease. It can be the long-term result of other problems.
Okay, that paints a clearer picture of the how. Now, what about the what? What signs might we actually see in a pet developing CKD?
Well, one of the tricky things about CKD is that in the early stages, what we call IR stage 1 and early stage 2, there might be very few, if any, obvious outward signs.
Really? So a pet could have kidney disease and seem perfectly fine.
They often can, yes. Kidneys have a lot of reserve capacity. So in those early stages, the main focus is often detecting it through screening tests like blood work and urinalysis, and then implementing strategies to try and slow down any further progression.
Okay, but eventually signs do show up.
Yes. As the disease progresses, typically into stage 3 and definitely by stage 4, those clinical signs of uremia we talked about earlier become much more apparent and usually more severe.
Remind us of those key signs again.
The classic ones are often increased drinking and increased urination, polydipsia, and polyuria, or PUPD. You might notice you're filling the water bowl more, or your dog needs to go out more, or the litter box is wetter.
Okay, PUPD. What else?
Vomiting is common, as is a gradual loss of weight, maybe a decrease in muscle mass. Pets often become lethargic, less active, maybe sleep more, sometimes described as depression.
And these signs are all consequences of the kidneys just not doing their jobs properly.
Essentially, yes. They stem from the buildup of waste products, the inability to balance electrolytes and fluids correctly, problems maintaining hydration, and issues with acid-base balance. It's a systemic effect of inadequate kidney function.
So if you notice your older dog or cat starting to drink tons of water, needing frequent potty breaks, maybe looking a bit thinner, kidney disease should definitely be on the radar.
Absolutely. Those are very common presenting signs. But it's important to remember other diseases can cause similar signs like diabetes or hyperthyroidism in cats. So you can't diagnose CKD on signs alone.
Which brings us neatly to diagnosis. How do vets actually confirm CKD? What's the process?
Diagnosis really involves piecing together evidence from multiple sources, usually in a patient that's stable, not acutely ill. We look at the clinical history you provide, the physical exam findings, and importantly, results from blood tests and urinalysis.
Okay, what are the key findings on those tests that point towards CKD?
Several things are highly suggestive. A persistent increase in SDMA, that's symmetric dimethylarginine, above 14 micrograms per deciliter, is a strong indicator, often rising earlier than creatinine.
SDMA.
Then we look for increased creatinine and SDMA together, always interpreted alongside the animal's hydration status, because dehydration alone can bump those numbers up temporarily.
Right.
A low urine-specific gravity less than 1.030 in dogs or 1.035 in cats, typically showing poor concentrating ability, is another big clue. Persistent renal proteinuria, meaning protein in the urine that's not from inflammation or bleeding, is also significant. We measure this with the urine protein to creatinine ratio, or UPC. A UPC over 0.5 in dogs or 0.4 in cats is generally considered abnormal.
So high-waste products, dilute urine, protein in the urine, anything else?
Sometimes we see abnormalities on kidney imaging, like small, irregular kidneys on ultrasound. And of course, worsening clinical signs consistent with kidney disease over time also support the diagnosis.
It sounds like a combination of factors. You mentioned stage 1 and early stage 2 might be harder to spot. How do we diagnose it then?
In those early stages, creatinine might still be within the normal lab range or only slightly elevated. That's where finding one or more of the other abnormalities becomes key, like that persistently high SDMA or the persistent proteinuria, or maybe subtly decreased urine concentrating ability or abnormal kidney structure on ultrasound.
So relying on more than just creatinine is important early on.
Critically important. And monitoring trends is vital too. Even if values are within the reference interval, if we see creatinine or SDMA consistently trending upwards over time, even subtly, that's evidence of declining function and helps document progression.
Okay, so once we have that diagnosis, the next step is staging using the IRIS system. What is IRIS?
IRIS stands for the International Renal Interest Society. It's a group of veterinary nephrology experts who developed a standardized system for staging CKD in dogs and cats. It helps us classify the severity and guides treatment recommendations.
How does the staging work? What's it based on?
After we confirm CKD in a stable patient, the primary staging is based on the serum creatinine level, ideally interpreted alongside the SDMA level.
So those waste product markers again, are there specific ranges for each stage?
Yes, there are. The stages run from 1 to 4, with stage 1 being the mildest and stage 4 the most severe. Based on the provided info for dogs, stage 2 might be roughly creatinine 1.4 to 2.8 mg/dL, and stage 3 could be 2.9 to 5.0 mg/dL. Stage 1 is below 1.4, and stage 4 is above 5.0. These are approximate ranges, and the official IRIS guidelines have precise cutoffs for both dogs and cats.
And how does SDMA play into the staging? You said it's used alongside creatinine.
Right. SDMA adds valuable information, especially when it seems to indicate a more severe stage than the creatinine alone suggests. It can act as a tiebreaker or an indicator to upstage the patient.
Can you give an example?
Sure. For a dog, if their creatinine is in the stage 2 range, say 2.0 mg/dL, but their SDMA is persistently high, like over 35 mg/dL, IRIS recommends considering that dog as stage 3 for treatment purposes.
Okay, so the SDMA suggests the kidney function is actually worse than the creatinine alone might imply.
Exactly. Similarly, if a dog's creatinine puts them in stage 3, but their SDMA is very high, over 54 ANGATL, we should consider them stage 4. There are similar guidelines for cats using slightly different SDMA thresholds, like an SDMA over 25, pushing a cat from certain stage 2 creatinine levels into stage 3 management, or an SDMA over 35, moving a stage 3 cat towards stage 4 management.
That's really useful. Using both markers gives a better picture. Now, I think the staging doesn't stop there. There's substaging.
Correct. Once the primary stage, 1 to 4, is determined based on creatinine and SDMA, we then substage based on 2 other important factors, blood pressure and proteinuria.
Why substage?
Because hypertension and significant protein loss are major complications of CKD that affect prognosis and require specific management. Substaging helps us tailor the treatment plan more precisely.
Okay, let's start with blood pressure. How is that substaged?
It's based on systolic blood pressure readings taken when the animal is calm. If it's consistently 180 mm Hg or higher, that's severely hypertensive. 160 to 179 is hypertensive. 140 to 159 is considered pre-hypertensive or at risk. And below 140 is normotensive or normal blood pressure.
And treatment decisions are based on these categories?
Yes. Generally, treatment is recommended for hypertensive or severely hypertensive animals to prevent damage to other organs like the eyes, brain, heart, and even the kidneys themselves.
Makes sense. And the other substage is proteinuria, based on that UPC ratio again.
Exactly. We use the urine protein to creatinine ratio. In dogs, a UPC consistently over 0.5 is considered proteinuric and usually needs treatment. In cats, the threshold is generally UPC over 0.4.
What about lower levels?
In dogs, a UPC between 0.2 and 0.5 is borderline proteinuric and requires careful monitoring. Values below 0.2 are generally considered non-proteinuric.
Does the stage influence how you view the proteinuria?
Yes, somewhat. For example, if a stage 3 dog has a UPC over 0.5, it really prompts a search for underlying causes. And if a dog in stage 1 or 2 has severe proteinuria, like a UPC over 2.0, that's quite significant and might warrant more aggressive investigation, potentially even a kidney biopsy to figure out the specific type of a glomerular disease.
Wow, okay, so the IRAS system is quite detailed stage based on CRSDMA, then substage for BP and UPC. That gives a really comprehensive assessment.
It does. It helps us understand the severity, predict potential complications, and guide our therapeutic approach much more effectively.
Right, let's talk treatment then. What are the overall goals when managing a pet with CKD?
There are really two main aims. First, we want to slow down the progression of the kidney damage itself, preserving whatever function is left for as long as possible. Second, and just as vital, is managing the clinical signs and complications to maintain the best possible quality of life for the pet.
And does the focus shift depending on the stage?
Generally, yes. In the earlier stages, like 1 and 2, the emphasis is often more on slowing progression. As the disease advances into stages 3 and 4, managing the symptoms of uremia and maintaining quality of life often become the primary focus, although we still try to slow progression where possible.
Are there any general treatment recommendations that apply across all stages?
Yes, definitely. Foundational things. First, stop any medications that could potentially harm the kidney's nephrotoxic drugs.
Good point.
Second, identify and correct any contributing pre-renal factors like dehydration or post-renal factors like an obstruction. Third, ensure free access to fresh water at all times. Hydration is absolutely key.
Okay.
Fourth, regular monitoring of those key parameters, creatinine, SDMA, urine, blood pressure, electrolytes, is crucial to track trends. Fifth, investigate and treat any other concurrent diseases or complications.
Like the hypertension and proteinuria we just talked about.
Exactly. We treat hypertension if blood pressure is persistently over 160 millimeter Hg, or if there's evidence of target organ damage, aiming to get it below 160 but avoiding making it too low, like below 120.
Right. And we treat persistent renal proteinuria, usually starting with a renal therapeutic diet, and then adding medications like ACE inhibitors or ARBs, angiotensin receptor blockers. But critically, the pet must be well hydrated before starting those RAAS blocking drugs.
RAAS.
Renin-angiotensin-aldosterone system. It's a hormonal cascade involved in blood pressure and fluid balance that we try to modulate in CKD.
Got it. Okay, those are the basics. Let's dive into stage specifics, maybe starting with stage 2 dogs.
Okay, stage 2 dogs. We apply all those general recommendations. Plus, this is typically where we strongly recommend transitioning to a prescription renal diet. These diets are restricted in phosphorus and protein and often supplemented with omega-3 fatty acids and antioxidants.
And medications.
Yes, an ACE inhibitor is usually started, especially if there's any proteinuria, to help manage that and potentially slow progression. If proteinuria is severe and not controlled with an ACE inhibitor and diet, sometimes an ARB is added cautiously, maybe with specialist advice.
What about other issues that might pop up? If their serum albumin, a key blood protein, drops quite low, say below 20 ground loss due to protein loss, we might consider anti-clotting medication like clopidogrel or low-dose aspirin. We also need to be ready to treat nausea or poor appetite if they arise, using anti-nausea meds like meropitant or appetite stimulants like capromorelin or mirtazapine. Some dogs might need subcutaneous fluids at home periodically to help with hydration.
Okay, moving to stage 3 dogs. What changes or gets added?
We continue everything from stage 2, but things often intensify. The renal diet and ACE inhibitor ARB therapy remain crucial. If proteinuria over 0.5 is present, we really need to look for causes, maybe even consider biopsy. Managing phosphorus becomes even more critical.
How do you manage phosphorus?
The renal diet is the first step as it's phosphorus restricted. But if the blood phosphate level stays above the target, which is around 1.6 millimole or 4.6 milli-GTL in stage 3, we add phosphate binders. These are given with food to bind dietary phosphorus and prevent its absorption.
What are common binders?
Aluminum hydroxide is common. Calcium carbonate or acetate can be used, but require careful calcium monitoring. There are others too, like lanthanum or sevelamer. The goal is to get that phosphate level down.
Anything else prominent in stage 3?
Anemia can become more common. If their packed cell volume, or PCV, drops below about 20%, we might start treatment with an erythropoiesis-stimulating agent like darbepoetin to help stimulate red blood cell production. We continue managing nausea, appetite, and hydration, often needing more frequent SHU-Q fluids, and we must be very careful adjusting dosages of any drugs cleared by the kidneys.
And stage 4 dogs, the most severe stage.
Stage 4 is really about intensive supportive care and quality of life. All the stage 3 measures continue, but often need to be more aggressive. The target for phosphate control might be slightly higher, maybe below 1.9 millimole or 6.0 milli-GDL, but binders are almost always needed.
What about eating and drinking?
Preventing dehydration and malnutrition is paramount. Nausea and appetite loss are often severe. We use multiple medications to control symptoms. Often, a feeding tube, like an esophageal tube, becomes necessary to provide adequate calories, water, and medications reliably.
Feeding tube, okay.
Parenteral fluids, IV or SQ, are usually required very frequently. Extreme caution is needed with all medications relying on renal clearance. And this is the stage where discussions about palliative care or advanced options like dialysis or kidney transplantation, if available and appropriate, become more relevant.
That's a comprehensive picture for dogs. How does it compare for cats? Let's start with stage 1 cats.
Stage 1 in cats is similar. Identify and remove nephrotoxins, ensure water access, monitor trends closely. A key difference is we treat hypertension if systolic BP is over 160, and we treat proteinuria if the UPC is persistently over 0.4, usually starting with a renal diet and an RAS inhibitor like telmisartan and ARB or benazepril and ACEI once they're hydrated.
Okay, and stage 2 cats.
Stage 2 cats get all the stage 1 recommendations. We definitely initiate a renal diet and a RAAS inhibitor, monitoring their response carefully, stable creatinine, hopefully decreasing UPC. Phosphate control becomes important if their blood phosphate is above 4.6 milli-GDL, aiming to keep it below that target, usually starting with the diet.
Anything specific to cats here?
We need to watch calcium levels closely in cats on renal diets, as they can sometimes develop hypercalcemia. Also, cats are prone to low potassium, hypokalemia, with CKD, so we supplement potassium if needed, usually with potassium gluconate or citrate. We treat nausea and appetite issues with meds like meropetant and mirtazapine or capromorelin. SQ fluids might be introduced. And remember that SDMA override, if SDMA is persistently 25 Ugidil, we treat as stage 3.
Right, so stage 3 cats.
Builds on stage 2. Renal diet and RAAS inhibition continue. Phosphate management intensifies binders are often needed if diet alone doesn't keep phosphate below 4.6 milli-GDL. We monitor calcium and phosphate closely. Some vets use FGF23 levels to help guide phosphate restriction. Managing GI signs and weight loss is critical, and feeding tubes are often considered. SQ fluids become more routine. Caution with renally cleared drugs increases. And again, the SDMA override. If SDMA is 35 Ugdale, manage as stage 4.
And finally, stage 4 cats.
Very similar focus to stage 4 dogs. Intensive supportive care, quality of life. Renal diet, RAS inhibitors continue. Phosphate goal might be slightly higher, maybe below 6.0 milli-GDL, but binders are essential. Anemia treatment with darbepoetin might be needed if PCV is below 20%. Aggressive management of GI signs, appetite, weight loss is key. Feeding tubes strongly considered. Frequent parenteral fluids are usually necessary. Extreme caution with drug dosing. And again, dialysis or transplant are options to discuss in some cases.
It really sounds like a partnership between the vet team and the owner is crucial for managing CKD, especially in the later stages.
Absolutely essential. It's intensive management.
So, wrapping that treatment section up, what are the key expectations clients should have when their pet is diagnosed? What should they be prepared for?
That's vital to discuss up front. First, understand CKD is progressive. It's not typically curable, but it is manageable, often for a long time.
Okay.
Second, the goals are slowing it down and maintaining good quality of life. Third, lifelong management and monitoring are required. This means regular vet visits, blood tests, urine tests.
It's a commitment.
It is. Fourth, diet is usually a cornerstone prescription. Renal diets make a big difference. Fifth, medications will likely be needed for various things: blood pressure, proteinuria, phosphorus, nausea, appetite, anemia. Sixth, learning to give subcutaneous fluids at home is common, especially in later stages, and owners are usually very capable of doing this.
Empowering for owners, too.
It really is. And finally, be prepared for the disease to potentially progress over time, requiring adjustments to the treatment plan and potentially more intensive care. Open communication with the vet team is absolutely key.
This has been incredibly thorough. We've really covered the nuts and bolts, what CKD is physiologically, what causes it, the signs to watch for, how it's diagnosed and staged with that detailed IRIS system.
And then we walk through the treatment approaches for each stage in dogs and cats, highlighting the general principles and the stage-specific strategies, along with setting realistic expectations for managing this chronic condition.
Understanding all these pieces really seems crucial for tackling CKD effectively.
It truly is. It allows for a proactive and tailored approach.
And just a reminder to everyone listening, if you have specific worries about your own pet, please talk to your veterinarian. They know your animal's history and can provide the best personalized advice and care.
Definitely. And for those who want to dig even deeper, the IRIS website, that's www.iris-kidney.com, has very detailed guidelines and information available for both vets and interested owners.
So a final thought, perhaps.
I think it comes back to partnership. Proactive monitoring, especially for our senior pets, catching things early if possible, and working closely with your vet team. That collaborative approach really offers the best chance for managing CKD and maximizing your pet's quality and length of life.